Okay, thanks everyone for coming. We got right to it. We're going to have Dr. Safer, Dr. Safer is the Executive Director of the Center for Transgender Medicine and Surgery here at Mount Sinai and a professor in the Department of Medicine. He's been a leader in the field nationally and done various professional committees and involved in writing national guidelines on the treatment of transgender individuals. So, lucky here to have Dr. Safer.
Yeah, good. Thank you. Sorry about this. I got my 15-minute warning when I was like a half hour late, and I'm like, how did I let them say that? I really apologize. So, what I want to do is, I was here. I have kind of a formal talk up there in terms of slides, but I did that. I was here last year for some of you at least, and I did kind of my formal talk in the past. And what I really want to do is get to a place where people are comfortable having patients come in. I think one of the things that's happened in terms of, or that should be happening in terms of care, is we really need to get over the idea that transgender people get diverted to some mental health person, and rather it's really coming into primary care, and then you see what it is that you need, and it depends. If you know a lot, then you need less, and if you know less, then you get endocrine or mental health or whatever it is, and appropriately to support. So that's kind of my real agenda, independent of whatever objectives I think I wrote. So I can kind of walk through stuff a little bit, or we could just divert to questions that people really have, and I'm open to. I've done variations on formats, and so what I thought I would do actually is I have about, I forgot, maybe a half a dozen slides on just what essential strategy is, and then I have about 6 cases, but the cases are important. I start with what I think are the important things, but we could just get diverted to what people's real questions are. So, okay, so no complex, the attack that's not label. Okay, so let's just go right here. So, just a very brief comment on terminology as I try to be a bit of a lumper as the field is kind of shifting. I think that I don't want that to get in the way. People want to redefine gender and sex, and they already kind of got redefined, and so the whole thing is just incredibly confusing. Gender refers to parts of speech, sex refers to biology. That's what I was taught. And now people want gender to be gender identity and sex to be body parts, and I just try to be much more specific in my talk, both with my patients and with people around me. Gender identity is gender identity, body parts are body parts, and gender and sex are these amorphous terms that get used interchangeably. I have a form that says sex, M or F, and then it has in parentheses gender, in case I was confused. So you can see. And I think we're comfortable with this cisgender, transgender, and gender non-binary are. Gender dysphoria is the old mental health term. That's what's still the coding diagnosis in ICD-10. We're stuck with that for a while, although for medical people, we're not supposed to be using these mental health coding diagnoses officially, depending on who the payer is. And so, for endocrine, I pick whatever hormone I'm giving, and I put a label somewhere along those lines as the diagnosis, and so that's a little confused. But then when you have somebody who needs a surgery, right now, half the insurance companies want the mental health diagnosis as justification for the surgery, so that's a little bit of a mess, and that's not getting fixed for another 5 years until ICD-11 rolls up, and they use something called gender encumbrance, which sounds a little bit more like transgender. All right, so and here, this is just what I was saying. This is the point: is that Endocrinology said we've been moving here slowly, and this is from 2 years ago, and this is a huge argument pulling the mental health, not saying mental health provider in that line, and we recommend, or I forgot what we say, it would be preferable that there would be a mental health provider involved. So it's still very conservatively written, but just taking it out as an absolute mandate was a huge piece in terms of getting where we need to go. And then I became a bit more aggressive, so I wrote reviews that are last year I wrote a review in Annals, by the way, and in terms of cookbook stuff, I think that the tables there in terms of the medications I hope would be useful, and if you have access, great. If you don't have access, I'll get it to you. And I wrote another review in New England Journal in December, so variation on theme, and you can see the language we move even farther over. I have a friend who's actually president of W Path right now who wrote both of these with me, and we move even farther over in saying primary care, this is how it looks. Oh, and it gets even more extreme. There's a paper coming out in Annals, February 4. I don't know if I'm supposed to say that out loud. That's it. I don't know, but it's a part of things. But anyway, so that's, but next week or whatever that is, where we take it to this is with another colleague of mine, the one who runs Transgender program up at the U, where I was before I came to Sinai. So she's primary care, actually. So she's even stronger in terms of that concept. And this is obviously the paradigm, which is how we take care of people in general. And okay, so strategy. So the thing is, we're seeing people present in adult and late adolescence because we don't have a test and we don't have a scan, and people have to be able to articulate their identity a little bit to us and how old you have to be before you can do that. And who knows what the story is, and it is obviously getting younger over time as people, but there's going to be a limit. We're going to see some kids, but for the moment those remain the minority. And then the other thing from a strategic perspective is that when we're at the level where we are providing care as we should be giving it, it's still the case that with our current technology, fertility is what gets compromised when you start playing with people's hormones, or even more dramatically if you're playing with people's gonads and surgery. So strategy, I think, is one of my old jokes, that the good news, it says good Lord Ethel, you can't hear about like that, and basically you can't tell which one's Ethel anyway if you don't know which way the balloon is facing, so we can all be relaxed that as our patient's age is going to be fine. But so for strategy, though, what I want to really focus on is this pair of identical twins. This is the picture that I always show. She's transgender. They're both XY. She's had puberty blockers. That's all that's happened. So she's having that kind of linear. We have that. Just a linear growth looks like female puberty to us at a distance. Whereas male puberty has this kind of inflection point where you get all the impact from all the androgen, and you are expecting the hair above the lip, but those getting grow bigger. Mandible getting square, SDM muscles getting bigger, soft tissue in the larynx causing this voice to go down, things like that. And so that's some of the stuff that we're going to deal with our older trans patients if they've gone through some of that puberty. And then in terms of what it is that we're really doing on the medicine side, because that's what you're going to do either on your own or with endocrine guidance, is we're manipulating testosterone heavily is the point of this cartoon. That is, it's true that the normal range of estradiol, to the degree that's a good surrogate for estrogens, is higher for women than for men. Really, the big difference is testosterone, where at least if total testosterone is a legitimate surrogate, and that's also a little bit of an if, but we don't have a very reliable free or any, all those free bioavailable are like even more useless than the total. So basically, the total testosterone is maybe a tenfold greater in men than in women. So for adolescents, at 10 or 2, which is the beginning of which is at the beginning of puberty, they get the puberty blockers, and then for the guys, just very quickly, we give them androgens, and we can talk about some of the specifics. But I'm kind of agnostic in terms of how you give testosterone. The patients are not so agnostic. That is, they all read online that they're supposed to get injections. And as an endocrinologist, I like that a lot because because you can get the levels good fast, and then you can see what's going on. And if you're willing to take a shot, it's easier for me as the doctor to actually follow things. It's the gels, and then if you have any experience with giving gels to guys who are hypogonadal, you know that they're not very efficient, and you end up having to raise the dose all the time, and they're a pain in their bother. So, but again, they do work. And so for trans guys, it's really just the same. And for trans women, the issue is that we're really blocking the testosterone, and the agent that we're using to block the testosterone is estrogen. And I think that's when people think about this strategically, that's the confusion. Is they think there's this battle between estrogen and testosterone. It's not quite right. What we're doing is we're giving estrogen to feedback centrally and push testosterone down. Now, it's not, people or women need some estrogen in their bodies. That is, if you look for people who have estrogen receptor defects, they don't grow breasts. So obviously you need some estrogen, but I don't know if that's a threshold effect. That kind of thing is not actually well worked out in the OB literature or any of the people who study this stuff. And so what I can say with some confidence is with an adult level of estrogen circulating, if your testosterone is low enough, then you get breast development and more of what we would expect from a female perspective, and we would just use estrogen to satisfy both of those, right? Because it can both cause suppressed testosterone centrally, and it can cause your estrogen, and then it gives you that adult level of estrogen and protects your bones and all these wonderful things. And we would just end right there, and that's what they were doing in the 90s. We see patients, by the way, who will come in on large doses of injectable estrogens, and those are leftover regimens from the 90s where everybody thought estrogen was the best thing you could imagine, and you would just kind of give it in large doses. But we have this caution where we worry about thromboses, and that looks to be, and there's a meta-analysis from British Medical Journal exactly a year ago, so January 2019, where they looked, and not trans-specific, looking at women getting estrogens, where the more estrogen you got, the more thromboses you had, no matter what the product was. And so it does look to be dose-connected. And then if you add progestins to the mix, it gets worse yet. And so, therefore, we want to maybe give a little less estrogen. And that's the concept of these cocktails of having some adjunct agent that also lowers estrogen. That also lowers testosterone. Is you need some estrogen, but if you could give a little less, it would be a little better and not to have waviness in terms of how much difference that all makes. All right, so that's my strategy. And now let's jump into things. And like I say, I have some cases here, and I can just kind of go into the cases, but if we divert to questions that you really have, that might be preferred. We have about a half hour for this, I guess. And by the way, it is part of my overall agenda to have this be like, and by the way, patients already think that cyanide's a trans-friendly place to come. Like I'm expecting you're already seeing that. In fact, who here already has at least a trans patient or two on the panel? Everybody, pretty much, or like half to 2/3 of you. Okay. So illustrative of where I think we're headed is, I think it's like a week or so ago, I had a patient come to me, new to town, transgender guy, lives in, got some apartment near the subway in Queens, was told that cyanides were to go, Googled, found an FPA with the cyanide label on it. That's where you're supposed to go. Went there. They have no clue what's going on. But they were very nice, and the patient, and they said, "Oh yeah, I think we do that." And then they went and they looked, and then they found us down in Chelsea. Referred the patient to Chelsea for hormone support, but they're still the primary care. Like they didn't give up the patient. And they're like, and the patient pretty much relates this to me as if that's what he was expecting. He was like, "Oh yeah, see, they said cyanide was right," and then they walked in and sure enough. So, point is, it's you. Anyway, yes.
Before launching into
Yeah.
the details of the case, I think we're fortunate to have you and your expertise here. I don't have a trans patient on my panel, so I'd really be curious, to know like an overall perspective, your sense of what we are witnessing here in terms of this dramatic change in both regards to medicine and sort of culture. So for me, I know it's always helpful to have a conceptual framework, and I think maybe my view is sex is biology, gender is a cultural construct. So what is your sense in terms of the movement, I guess, if you will, of what we're seeing? Is this that we're just kind of catching up with the times, and there's always been this fluidity, throughout the history of humankind, and we're just now able to kind of tackle this? It's helpful for me to get a sense of what we're experiencing before I say, okay, I need to send this person, or I need these hormones, that sort of thing.
Sure. So let me frame that just a little bit, and it really goes like this. Over the past decade or so, and I have, and that's part of one of my other talks even, but I'm happy to go over that otherwise. There has been a recognition that gender identity is actually apparently got a substantial biological component to it, and our evidence really is that we cannot. Our evidence comes in kind of 4 flavors, but among them are that we cannot manipulate gender identity in intersex people, even though we thought we could, because we thought that gender identity was not a biological thing, and various and sundry other association studies. Like if you look at twins who are transgender, if you've got if your transgender person has a fraternal twin, the chance the twin is also transgender is pretty low, similar to other sibling pairs. But if you've got an opposite of the picture that I showed, actually, if you've got a transgender person with an identical twin, the chance that identical twin is also transgender is maybe 40%. It's just suggesting that the more DNA you have in common, the more likely you are to be transgender, independent of the fact that all these twins were raised by the same parents and things like that. They all have the same nurture element to their existence. And we have some data with regard to androgen exposure, and on it goes. And the bottom line of it is that there seems to be some biological component to gender identity, and that's the problem with all the language, is that we call it gender identity, but we should probably call it sex identity. If we're going to be rigid and say gender is which is what we used to do in English, and say it's a part of speech or whatever, and sex is the biological thing, then we should be calling it sex identity. And okay, we should, but we're not. And and the term transsexual kind of got gobbled up by the people who were using it to mean absolutely everything according to some party line position happened, including hormones and surgeries and things like that, so that the broader umbrella term became transgender, which also makes no sense if gender is part of speech. But there we are. So the point is, sex is biology, but if we look under the rubric of sex, where we look at chromosomes and genes and genitals, gender identity is also one of those biological things under the word sex. That change really has influenced how medicine approaches the whole thing, because if that is true, then we can just be logicians and say, okay, well, how are we going to deal with an incongruence between gender identity? Just this element of you is coded differently than other elements of you, which we see in intersex conditions. Just some of them are more visible. And so if that's, and we could counsel people to deal with it, which is kind of what we were doing for decades, with about a 40% suicide attempt rate. So that was like not successful. And then what the idea of giving people whatever it is that they want in somewhat of a customized approach, which is variable among people, is whether it's hormones or surgery or mixture or whatever, for those people who want it, which isn't even all transgender people, then all of a sudden that's a very successful approach, and that's where we are in medicine right now. And so that's what's really changed. And that it's not the celebrities and it's not society. I think that helps. But the difference, we've been here before. I've actually lived through it before. In the 70s, we already did this. We had Renee Richards, and it was all very public. But all of medicine was like, ooh, that's pretty weird. I think it's a mental health concern. And so there wasn't buy-in. Whereas now, this time around, with very new celebrities, we're all saying, oh yeah, that's a real thing. Come to primary care. And here we are. And I'll just say one other little piece for you, because when the person walks in the door, it's going to go like this. The adults know their gender identity for the most part in a relatively reliable way, unless they don't. And so therefore, somebody who does not have a confounding mental health explanation for why they would be giving you a confused history, if they come in and they say they're transgender and looking for hormones, they're pretty much transgender and looking for hormones. And it's a little bit like other mental health screen for primary care. We don't have enough mental health people to do the screen for you in a perfect way. So you have, like, when you screen for depression, you have a few questions you ask, and maybe you try Prozac already on your own, or SSRIs. It depends on your comfort level, right? But and things get a little bit more complicated before you start pulling mental health in. And so there's an element of this too. Somebody comes in, they don't talk to you. They say they're transgender because there are people like on various spectrum people overlap situations or whatever. Okay, fine. You're going to be like, okay, maybe I want some mental health support with that. But some kid walks in and says, okay, I'm here for college. I'm ready for my hormones. And I thought this was a convenient time to switch it over. I've always been transgender. Da da da. I have no disease in the family history is nothing. I think no allergies. My folks know everything. You're like, okay, good, yes.
You may do this as you go through your cases, but just two things I would love to know more about. One, how to speak about genitals, because I understand for a lot of people who are transitioning, you don't necessarily want to refer to it in the way that we typically how to tailor my language. So that's one question, and another one that you may also speak to is how to address screening in a way that feels like age-appropriate cancer screenings in a way that feels comfortable.
Okay, good. Yeah, let me talk about that because that's not part of my cases, and you know, some of this is a bit of a mindset. You'll have other people who come in and they will devote a huge amount of energy to that, and I almost feel like it's on par with some cultural competency stuff that we learn, where the cultural competency talk is almost more incompetent than how we would behave. You know, and it's filled with stereotypes about ethnic groups. I don't know how it is, what the current is, because I haven't done it for a little while. But every time I've done it, it's filled with stereotypes about ethnic groups, where I'm like, well, and then I have patients who are like, well, that doesn't apply to me. And I'm like, you know, and taking people as humans and individuals is really cultural competency, and you have to kind of ask. And I guess I would say it the same with transgender people with regard to this. So I try to be more medical in my language so that we know what we're talking about. And there are pejorative kinds of things that are out there, and there are generalizations that are out there that are very confusing. And I'll just give you some examples. So we used to say sex reassignment surgery. So I don't even know what that means. It's a little pejorative anyway, because they're like, well, this is the sex I've always been, just nobody knew. And so there's nothing getting reassigned. And it all comes from the intersex world anyway, with that kind of language. And then what does sex reassignment surgery even mean? Because if I got a transgender guy, most of the time, because the genital surgeries are not that, have concerns, which I can go into, most of the transgender guys are just getting chest surgeries and hormones. So is that sex reassignment surgery? You know, so it just gets very nebulous what we're even talking about. So I like to say, chest surgery, genital surgery, you know, pretty concretely using the medical terms. And then genital surgery is not just that, I might need to get more specific. And I say vaginoplasty, which is creating a vagina, or phalloplasty, creating a penis or whatever it is. And then even some of the so-called PC terms get sloppy. So I happened to be just a couple weeks ago in Vietnam, which is kind of a crazy story. The Vietnamese are like the only dictatorship I know in the world that's actually interested in having trans care for their populations as opposed to demonizing LGBT people. But okay, good, we took it. So I was in Vietnam with a whole group of people doing some trainings for some of the medical providers, and I know I had medical school there, and my colleagues, especially in the mental health field, are like not so medical in how they talk, and they use kind of these phrases like, I don't know, assign male at birth, and like the Vietnamese people, their English is just not good, you know, and you can't do that, and you have to be a little bit more concrete and use real terms, and they know, and think about the language that we're talking about, like you shouldn't use parts of the body terms because maybe it'll be offensive to your patient. Just imagine doing that in Vietnam, like they're like, what? And we have to say vagina. Oh, vagina, because they memorize that in med school because their books are still in English, you know. So I like to be specific and not be PC, but I listen to my patient because sometimes my patients really care and it's a sensitive point, and so it's okay to follow the patient's guideline. But I think that's true for a lot of stuff. And I will just tell you as a practical matter, I've not done stats on this, but it's a rare experience for me to have a patient. Again, I'm very sensitive, and I know transgender. I don't like misgender them, and you do have to pay attention to that. Like that's the thing to really watch. Like, are you using their name correctly, or somebody who doesn't have an appearance to match gender identity yet, but they came in and they told you that their pronoun was she, but they're looking pretty masculine, and then you can't call that person sir or mister, you know, and that, you know, and if you're, you know, that's the kind of stuff that will get really offensive fast that you need to work on. But when we're saying, okay, we're talking about, I'm interested in what kind of surgeries you're interested in, you can ask that in kind of open-ended way. Most of the time you're like, well, I would like to get rid of the breasts. That, you know, they're not like, oh, I can't call these breasts because I'm a guy. You know, and so is that helpful? Framing that anyway? No, so why? Well, first of all, that's sloppy. Okay, that just is not medical talk. Okay, and second of all, why should I put all transgender people in this box of people who are having a hang up about the body parts that they really have, because my patients are not mostly having a hang up, they're transgender. Okay? And it doesn't mean there won't be somebody who will say, well, I don't like to use that term because it's triggering. And you're like, okay, fine. Then you make a little note on their chart.
I just didn't know where to start.
Fine, yeah. So my find is start being medical, and then be open to diverting, but don't start with some PC lingo and then you have a patient who's like, well, I don't know what a front hole and a back hole is.
Why are we going there? Yeah.
Exactly. Do you go number 1 or number 2? I mean, how can you choose? Anyways, yes.
So I had a patient come in who was trans and he wanted top surgery, basically. Like, it was just a situation where he was worried about a voice change because he's a singer and he wanted top surgery. And I was like, this is well beyond my ability to manage this. And I had so much trouble trying to get him into care. And I think he was actually lost in that process between coordinating with surgeons and you all. And so I'm just trying to figure out, in that situation, how do I better navigate for it? Because I don't think I advocated well for him, and I still feel bad about it.
Okay, so a couple things. So we have one dedicated phone number, and everything begins there. And we're incredibly low tech right now, where people actually have to call the dang phone number. It's not like an Epic consult or anything like that. And then everything gets triaged out of there. And then people who are in the system and need something else, go back and call that main phone number again. So it's the number that's on the website. It's 212-604-1730.
Because we called that number together in clinic,
Yeah.
and we're basically told, okay, we'll call you back.
Right, that's
Sort of
right.
thing,
They
yeah.
take a message. So to get expectations correct here,
Yeah.
that's the Sinai phone service. We have the best people working for us. They don't misgender people. They pick up on like 4 rings. They take a message, but they do take a message. You're not in the clinic.
Yeah.
You're at you're at the phone service. But they do pick up. Like a live person always answers. You don't go to voicemail. And they take a message, and then somebody from the program calls you back the next day. And it kind of depends what you're looking for, who calls you back. Because if you're looking for a chest surgery, then that's gonna the message will get to somebody. If you're a kid, you're gonna get called by the peds group. It's things like that.
Yeah. So I think that was where the link was broken, and I didn't know how to fix it.
Yep, and then I have 2 more. So that's all thing 1. And thing 2 is yes. You should reach. You're the medical folks. You can reach out directly to me and say your program is broken, or whatever.
It just didn't work.
And just send me an
I didn't
email.
know how to, like,
No, but I think you should feel confident about that. And then one of the things that we're going to have to institute, which we've already done we have, I don't know, about 4 champion programs so far in the city. We're going to do more of this. Is what's your backline, or at least your email? Because I think that's what it is. It's not so much a backline because there's nobody necessarily sitting at the backline, but we have a nurse liaison whose her day job is to reach out to people and make sure they're navigating the system correctly. And her name is Erin Connolly. And again, I can give you that information. And my admin people are same thing. You would reach out to them. You can reach out to me, and I will forward to the right person. We have a nurse practitioner who's part of her job description. She just started in November, is coordinating among primary care around Sinai. So that's my part 2, which is for the worst comes to worst, you can't think of anything else, you send me an email, I'll forward it to the right person and say, okay, a ball seems to be dropped here, whatever it is, and then we'll make sure somebody gets reached out, or whatever it is, or you have a question, you're like, what's supposed to happen here?
Is that stuff in the
We should put it in the app.
Yeah.
It might not be.
And the
Yeah,
one
it's
other,
just
for transgender, it's not in the app.
and the one other thing that I said there were 2 things, but there's a third thing. And the third thing is that we are in e-consults. That's our one electronic thing. So if you just have a quick question, because you're actually managing patients' time, and you're like, is this really true? Should I do more? Or whatever, and you don't want to send the patient for a consult out to Chelsea or whatever, that you can do an e-consult. In which all those e-consults come to me, and I'm not overwhelmed so far. So I'll answer that question.
Give it time.
Be careful what you ask.
Good. All right. Other questions? This is good. This is like more important. Yeah.
maybe you'll get to this in these cases, but most of the patients, the transgender patients that I have are patients that are already, have already been through the process, have, either had gender reassignment surgery or what have you, and I'm kind of inheriting them. What I think I struggle with on this, in this practice, is when a patient comes to me and says, I don't, I think I'm transgender or something like that. That's probably where I get stuck most, because the problem is I don't exactly know where to start. I'm assuming that, or the way I felt most comfortable was kind of letting the patient help navigate, just because they tell me that doesn't necessarily mean that they're looking for hormones right now or what have you. So I think maybe you'll get to this in the cases, but where do we go when we kind of are first introduced to that by our patients?
Yeah. So I guess what I would say with that one is that's it's a little bit like anything in primary care, where some things are going to be more straightforward and some things are less so, and you should be very casual about referring the people about it more or less so, because the whole point is that that you should be just taking care of the people who are straightforward. But the people who've inherited, fine, and everything's steady state, no issue. And if you have the case of, like I said, the kid who comes in and says, I'm transgender and this is what I want, and you're basically, okay, this is what the standard protocol is, and they're like, thank you, and that's your whole, great. And if you have somebody who's like, well, I think I'm transgender, and well, maybe that is somebody who needs to come down to us and sit to mental health, okay? And I don't have a group of questions for you to help work that out. That's, I think, getting beyond primary care. Or somebody says to you, what's the relative safety of this hormone? Or I don't want that conventional thing because I heard on the internet. And okay, fine. That's that. Now it's like, okay, then I'm going to refer you. Yes, of course.
I'm sorry, before we do the cases. So
Yeah.
I noticed in EPIC there's been an effort to start to put in patients preferred gender pronouns in EPIC. And I guess I'm just wondering, if you have a trans man coming in who needs a mammogram, are we at a place in our system where that is a comfortable experience for them? But I guess, are there better, I know some patients don't like to go on the 6th floor here and they prefer to go to, Dubin. I'm just sort of wondering what your experience has been for patients and if you have any thoughts on it.
Yeah, so the short answer is we're a massive work in progress, and people are gung ho but stupid, and people we're moved beyond people having bad attitudes for the most part to gung ho and stupid, and I think that's and that's kind of where Sinai is right now, and I can't promise any given situation, and you can. Run a little interference. It's almost like when you send somebody for a surgeon and anywhere they might have bad bedside manner. I'm saying you might say the same thing. You might have to give them a little bit of bad experience conversation to up their resilience. So I do want to caution that we're getting there. I love the pronouns. It's an IT workaround because we actually do not have gender identity in there because it's not because of EPIC, it's because of all the other computer systems don't talk to each other correctly and they all keep crashing. And the pronoun thing is a Sinai special thing, and I actually like it a lot because it's a practical matter. Having the patient coded correctly isn't all that important. Having the patient, it would be for data collecting purposes, but day in and day out when we're actually dealing with the patient, having the pronoun in our face is actually really convenient. So I like it.
I had a patient have the opposite experience. She's sort of a conservative older woman who a plastic surgeon had done her breast cancer surgery, and she went back to see him, and his practice now is mostly transgender surgeries. And she walked in and she said, I was worried I was in the wrong place because I was the only person who was born with breasts in the waiting room. And she said it was fine, but she's like, I wish you had told me. And I was like, oh, I didn't really think to tell you. It didn't even dawn on me. So it was just kind of a funny thing because he had done her surgery years ago, and she was just going, because she had an issue. And she was like, yeah, but she's like, I made some friends. She said, but I was a little surprised when I walked in, worried I was in the wrong place. So it's just funny how it can be the other way too.
Yep. All right. So so we're gonna go through. We're gonna have one of our 6 cases only, which is just fine, and we can do more, but basically, this one covers a bunch of territory actually. 17-year-old person with male gender anatomy tells you, I am a trans woman. I just arrived at college. It's like exactly that in this scenario. I've been living as a boy, never had any hormonal surgery, and but none of that's been all over the internet, and it doesn't want spironolactone as, even though that's the main cocktail, is spironolactone by an estrogen, and wants to consider progesterone and finasteride instead. This is like, so I'm just gonna, let's see, oops, what did I manage? Well, I'm never going. Okay, so what are we going to do? So comments on this. Let's just go through the different bullet points.
Just call it young.
Yeah.
I don't have patients that young, but that's still technically, less than 18, legally still a child.
Exactly. So that's important to be aware. By the guidelines, we actually insist on a mental health provider being involved for kids who are under 18. So technically, that would be part of the package. It should be going to adolescent medicine and having a mental health provider, even though they're totally straightforward, right? So yeah, something to just know about a little bit. Okay, good. But let's see what other stuff. And then in terms of cocktail, I'm just going to go through cocktail a little bit because that's what it is. So would you prescribe hormone therapy? And that's kind of the pause, right? Is knowing that. I've had a few people come to see me where they're like, I don't know, VIP parent kind of situations. And my rough rule for kids in that age group is that if you show up with your parents and you otherwise are acting like an adult, I can do your endocrine for you. I'm not doing fighting with the parent thing. I just don't have the peds situation going. My adolescent group will do that, but I have had that with thyroid before, so I use that's what the model in my brain is. I like, you showed up with your parents, they want me to do an adult approach, not a peds approach. You and your parents want me to do that, I can do that. And let's see, patient also wants to know being androgynous can be an option and only using testosterone lowering meds. So comment on that last one. Why not? And the short answer is, if we're talking about bugaboos, our biggest concerns really, we have a little bit of a fear of blood clots, but our biggest concern is making people hypogonadal and not protecting their bone over time. And so the short answer to that is no, but I don't know to what degree. So I know that absence of hormones is, especially in a young person, where I'm going to have decades of this, and we screw it up sometimes. We see this in endocrine, where somebody had like premature menopause and nobody replaced the estrogen forever and ever, and now they're in trouble. And we definitely don't want to be doing that by an act of commission. So that's actually one of the things that's not an option for them. They do need to come, but I don't know how much they need. Do they need a low dose? So there's a lot of handling. And here, this is just data that goes with that, which is just essentially a bunch of Z-scores on a one-bank study on a subject, where this is people starting on puberty blockers, and they fall behind their peers, because the Z-scores is not the Competency went down and fell behind their peers. And then they did get 6 years later, and they don't even completely catch up. So we definitely don't live in that peers. Not by our commission anyway, or not telling them it's okay. And then the other, okay, so in terms of hormone regimens, I think the key points are, and this is all, if you go to the reviews that I mentioned, they have those fairly convenient cookbook kind of situations, so I don't have to tell it to you, but the key points with estrogen therapy are first of all, that the old estrogen, ethinyl estradiol, which is the one in birth control pills, is the most thrombogenic. And it kind of cuts both ways here, because we avoid it in transgender people, because that's the one for which we've observed the most thromboses and for which most of the thrombosis data have been generated. But it also accentuates that the thrombosis risk is relatively modest, because we give this out to people with birth control pills, no problem. And why do we do that? And I'll just give you some numbers. Not exact numbers, some relative kinds of stuff. It's true, and when we look at it, and I don't know if I have data in here or not, but when we look at transgender women getting exogenous estrogens versus, let's say, cisgender women or cisgender men, we see increased thromboses. Okay, Okay, so it looks like it's really true that when you give exogenous estrogens, you do see more thromboses if you look on a population basis. And it might be, I don't know, twofold or fourfold or 3 extra cases per thousand. You know, there are different ways that this gets characterized, but it's detectable. But then if you look at women on birth control pills versus not, then they have the same kind of increase. In fact, they have a greater degree of increase. But if you look at women on birth control pills versus having an abortion or a pregnancy, then that's way less. You know, decades of birth control pills is like, you know, is like 1/10 the thrombosis risk of 1 abortion or 1 pregnancy. That's why we justify this no problem. And but if you're thinking about transgender women where we give them those estrogen regimens and their thrombosis risk is increased, a woman on birth control pills has even a higher risk, and an abortion and the pregnancy is way up here. And so our whole conversation about transgender women is down in this little range. And that's, I think, the important thing. It's not that it's not true, but it's way down here in a range that we can consider completely acceptable.
Has it lowered the dose from 0.5 to 0.3 to 0.2 to 0.1? Has that just gone down?
Yes, it definitely does. Which is, in fact, the biggie is the 0.5 to 0.3.
Right.
Like the 0.3 to 0.3 is a little more nebulous, but the 0.5 to 0.3, right, made a big difference. That's why we did it.
That was a long time ago.
Yeah, that was.
So the 0.3 to 0.1 hasn't changed that much.
I'm not aware of that because it's so hard to see the risk for the young women at that point at 0.3 already. That 0.2 and 0.1 is like, but the 0.5 to 0.3 was a big difference. That was very visible. And then higher doses than we see when we're giving like postmenopausal medicine. That's the only other thing to observe. And I think what else? And then this is stuff that's available cookbooky. I don't do so much in the way of injections because they're harder to measure. And the gels, it's sometimes and the patches. It's more patches for women. It's kind of hard to get their levels up, and so they kind of get annoyed with the patches more often than I do. Further comment on injections is there is talk about first pass effect through the liver being relevant for thromboses as a reason to favor a parenteral estrogen, but I'm not sure which is the more concerning issue: the first pass effect versus the dose response effect. Because the dose response effect is paramount. Then an injectable is actually going to be a bigger problem because you're going to end up with more area under the curve with this cyclicity. So just things to chew on, and I don't have data there. And I think we're kind of at our hour because we talked about other stuff. So I think we'll just kind of end with that. And we could do more cases at a time, or we could just have back and forth and have your real patients be the cases, which is what I think is probably next steps in real life.
Would you prefer we use the email or e-consult for that?
It depends on the circumstance. Like if you do e-consult, yeah, I mean, basically I sit and do them once a week, so recognize that I'm kind of batching up. You know, they're not like real time. If you have something urgent and you need a quick question, then obviously that you use email for that, as that is real time.
Thank you very much.
Sure.
Thank you.